This is MD Roundtable, a show about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. I interview a variety of healthcare professionals from all over the world. We have so much to learn from each other. I'm Dr. Ted Thachenkary. Thanks for joining me today. Hello, everybody in podcast land. Thanks for joining MD Roundtable. Super excited today as I have Dr. Khaled Asi, who is an endovascular surgical neuro-radiologist at Advocate-Aurora Health in Illinois. Welcome to MD Roundtable, Dr. Asi.
Thank you very much, Ted. I'm very excited joining you this morning.
Likewise, Dr. Asi. First off, I'd like to know a little bit about the background of my guests. So I'm just going to start off by asking you, where you grew up, where you went to college, where you went to medical school.
So I grew up in Madison, Wisconsin, Ted, and I lived my early years there up to early teenage years. And then, my family, my mom and my dad were studying at that time. My dad was a PhD student at UW-Madison School of Electronical Engineering. My mom was a nurse and a midwife. And then we moved back to Syria, where I did my med school, and it was a 6-year program at the University of Damascus in Syria, Damascus Medical School. And I moved back as a senior medical student. I came back and I pursued further graduate medical training.
Great. So sort of a non-traditional approach.
Correct.
And Dr. Asi, what was your biggest motivator that got you into medicine?
I think into medicine was an influence of my mom. She was a nurse, a midwife, and, kind of seeing her going to work over the years when I was really young and taking care of people. And then also my dad had influence on me too, because he was a doctorate in electronical engineering. So I got exposed to computers, to circuits, to that entity of engineering. And that what made me further interested more in the brain, as I imagine it as a big circuit, neurosciences. And I pursued training in neuroscience and neurology. So I would say both my mom and my dad had influence on me to reach what I did today. So
That's great. Yeah, that's a good little mix of both parents.
yeah. So they're both happy.
Yeah, I bet. Khaled, what has been some of your biggest challenges on your journey to becoming an endovascular neuroradiologist that you've had to overcome?
I think each step in the route was faced with its own challenges. So for me, getting into endovascular was a really long journey for me. So after I finished medical school, I pursued neurology training and at that time exposed to stroke. And then after I finished my neurology training, I pursued a neurocritical care training at Cleveland Clinic. And that was to further in-depth my clinical skills in taking care of stroke patients. And then I did another stroke fellowship after that. And then during that time, this was around 2015, is that when all the advanced stroke therapies became standard of care. So I pursued further training in endovascular after doing a stroke fellowship. And that was 2 years. I went to the University of Iowa in Iowa City. So the journey was pretty long. It took me a long time to get to the endovascular field. But it also, despite all the years that I invested in medical training and education, I think it requires all this training to better understand the disease process, the ins and outs, and to provide the best care you can for your patients. So it all comes at a price, and you want to be good at what you do, good in delivering the care that you promised to. And that was the major challenge, really, the time invested in this and, making sure that going to the best institutions around the country to learn this field and stroke overall.
That's great. That's great, Dr. Asi. Yeah, it looks like, like the most of us, in medicine, we're students for life, right?
That is correct. That summarizes it really nicely.
Great. Well, I'd like to get into the crux of the talk. Since May is National Stroke Month, I think it would be very fitting to discuss the various types of strokes for our listeners. So, Dr. Asi, can you explain what are the two main types of strokes for our listeners?
So we have an ischemic stroke or a lack of blood flow stroke, and that counts up to approximately 85% of all strokes that we see. And then the second type is a hemorrhagic stroke or a bleeding stroke, and that results in a bleed in the brain, basically.
Okay. So, Dr. Asi, can you just explain to the common person what a hemorrhagic stroke is?
A hemorrhagic stroke, in simple words, is a bleeding stroke. It occurs when a small blood vessel in the brain basically ruptures, it bursts, and results in a brain bleed. That's one type of it. The other type is if there's a brain aneurysm and the aneurysm bursts as well, that results in a different type of a brain bleed as well. These are bleeding strokes happens when a brain bleed occurs, and this counts for approximately 15% of all strokes. The majority of strokes are the ischemic strokes, or what we call the lack of blood flow stroke, when a clot obstructs blood flow to normal parts of the brain, which results in symptoms.
Okay. And Dr. Asi, how do you diagnose these types of strokes?
So, diagnosing a stroke most of the time starts at the field. What I mean by that is we try to educate our communities basically in symptom recognition of a stroke, and we use a synonym called Be Fast. Be Fast basically is we look at the letters B, balance. When a patient or a person is having problems holding their balance, not able to walk, that could be a sign of a stroke. If someone is not able to see out of one eye or both eyes all out of a sudden, that could be a stroke. If there's facial droop, either the right or the left side, patients start drooling, that could be a stroke. If patients are not able to move their arm or their leg on one side of the body. Speech, if suddenly a person starts to have slurred speech, they cannot understand what's going on or cannot produce words that make sense, that could be a stroke as well. So all these together, if anybody spots them, the next step is to call 911 and alert EMS.
Great. Thank you for that. I think that's super helpful for our community members to know that Be Fast symptoms. So, Dr. Asi, what are the treatment modalities and advances in stroke treatments?
So once the EMS picks up the patient and go to the hospital, that's where all the processes of stroke treatment start. The first step is to obtain brain imaging, and we usually start with a non-contrast head CT. The non-contrast head CT helps us define, is the stroke a lack of blood flow stroke, or do we see blood on the brain? If we see blood, we know it's a hemorrhagic stroke, which is a different pathway. But right now, since the most common stroke is the lack of blood flow stroke, we're going to be talking more in details about that. Once the CT is done, Ted, and we don't see any blood, the second important question is, when was the patient last known normal? Which means, what's the best time that we could identify has passed since the stroke onset of symptoms? And sometimes it's really hard to identify if the stroke is not witnessed. So that's why we don't ask, when did the symptoms start? Because sometimes we don't know when the symptoms start. We ask, when was the last time the patient was normal, was able to speak normally, was able to move their arm? If it's within 4 hours and a half, then patients get a blood clot busting medication called TPA. And that blood clot busting medication helps basically burst the clot that's obscuring the blood flow to that part of the brain. That could happen up to 4.5 hours since the last known normal of the patient. Let's say the patient comes after 4 hours and a half, right? And most of the time, that's what happens, is that we take the patient and we obtain blood vessel imaging, which is called a CT angiogram or an MR angiogram. And what this study does, it looks at the blood vessels all the way from the neck to the brain to try to identify if there's a clot in a major blood vessel. And this all happens, in emergency departments all at the same time. Whenever a code stroke or a patient with a stroke hits the emergency department, these all processes get activated simultaneously. So patients, no bleed, he gets the blood clot busting medication. At the same time, while the medication is going and dripping, the patient gets the further brain imaging. If the non-invasive image, which I mean, if we do a CT angiogram and we see a major blood vessel shut down, even if it's after 4 hours and a half, Ted, that's where the endovascular physician will be notified, like myself. And this is extremely important because up till 2015, these treatments were being offered, opening the blood clots in the major blood vessels of the brain. But in 2015, this became standard of care all over the nation, which means if a patient shows up within 6 hours with a blood vessel shut down in the brain, with a CT brain that looks okay, then we could go in with our catheters and we could pull the clot out and restore blood flow to the brain. And this is one of the major advances that occurred in medicine over the past decade, because out of almost 3 patients treated, 1 patient will have a really good outcome and go back home. So every 2.7 patients that you treat, 1 patient will have a really good outcome.
Those are great numbers.
It is for sure. So that's what was going on in 2015, Ted, is that we started opening blood vessel up to 6 hours of last known normal time. More studies were being conducted between that time up to 2018. And then in 2018, even patients who present to the emergency departments with stroke-like symptoms between 6 and 24 hours, and they have favorable imaging, those treatments could still be offered, and patients are having good outcomes as well, stroke patients.
So even up to 24 hours.
That is correct. Believe it or not, Ted, even more than 24 hours, if you do brain imaging and the stroke is not large, then we could still offer these treatments, and which is extremely important because, as you know, stroke is the leading cause of disability in North America. So the faster we get patients who are suffering from stroke-like symptoms to emergency departments, the better the outcome. And another more important thing that we're talking about right now, about the more technology that's being employed and advances right now. What we used to believe in the past is a large stroke. There is some preliminary data that even those patients, if you take the clot out, they will still do better than keeping the clot in.
Yeah, that's amazing.
Yeah, so I mean, the most important message that I would like to deliver through your podcast, Ted, is that even if it's a minor symptom, even if the patient gets better, I would still call EMS. I will still come to the emergency department and, be safe rather than sorry.
Sure. I do have a question, Dr. Asi, regarding the TPA administration. So let's say a patient gets TPA, qualified for the TPA. However, their symptoms do not improve. Can they still qualify for endovascular procedure?
So if the patient gets TPA and they're not getting better and the vessel, we still could see a vessel that's occluded or shut down, then definitely yes, we will still chase that blood clot and take it out, because TPA is not going to be able to dissolve all the clots. There's going to be clots that are refractory to TPA. So giving TPA does not exclude endovascular therapy.
Interesting. Thank you for clarifying that. Now, are there contraindications for someone to qualify for endovascular procedure?
A couple of things that may exclude current patients from getting endovascular therapy. But the first one is if a patient comes in and they already have what we call a completed stroke, which means the brain tissue that corresponds to that blood vessel territory is already dead. It's stroked out. In this kind of situation, you cannot offer treatment because there's really nothing to save. The brain tissue is gone.
Sure.
Number 2, if patients get TPA and they start improving rapidly, that means the clot dissolved. So there's no endovascular therapy to be offered here. Again, the third issue is that if they have minor symptoms despite having a large blood vessel occluded, for example, somebody had some numbness in their right hand and they have a large vessel occluded, we use a scale called the NIH stroke scale, which is the National Institute of Health stroke scale. It goes from numbers from 0 to 42. It's a measure that we use to assess the severity of stroke. So if a patient has a score less than 5, which we consider mild, we may watch the patient because the symptoms are too mild to offer taking the clot out of the brain. But we have to remember, as of now, there are clinical trials that are being conducted to study whether even if a patient has mild symptoms and they have a major blood vessel shut down in their brain, some people believe that we should still open that blood vessel in the brain, even if it were minor symptoms. And we will know, hopefully, the answer to that in the upcoming years.
I see. Very exciting stuff, Dr. Asi. You're obviously at a tertiary care center. Now, all hospitals around the country may not offer these types of procedures. So what happens then if a patient goes to a hospital or ER and that specific hospital does not offer that service? What happens?
Hospitals in North America are identified into two categories, mainly the majority of hospitals. We have what we call primary stroke centers and comprehensive stroke centers. A primary stroke center is a stroke center that's able to take care of a stroke patient and offer thrombolysis, which is the intravenous TPA, giving the blood clot busting medication through a IV. A comprehensive stroke center is a stroke center that's able to do what a primary stroke center can do, plus having the endovascular capabilities of going in and chasing the clots, and also having a neurocritical care unit as well.
Mhm.
So if a patient shows up in a primary stroke center, what happens is that emergency department reaches out to the comprehensive stroke center and say, this is what we have. We would like to transfer the patient to you. And that's what happens, is that the data, and people actually looked into this, is that patients need to be transferred to the closest comprehensive stroke center to get treated. Because the most important message that I want to deliver, Ted, is that the fastest, the quickest a patient gets his blood or her blood vessel open, the better the outcome. So even within 6 hours or within 24 hours, even though they will do well if we open that blood vessel within that time limit, but the earlier, the better. Because each minute we miss, or the moment a blood vessel is shut down in our brain, we lose millions of neurons of brain tissue cells every minute. It's like time zero. Patient have symptoms, we have to start, and the goal is to get that blood vessel open as soon as possible.
Sure. Yeah. Time is brain, right?
That is correct. Time is brain.
Fantastic. Yeah. I think this will be super helpful for our listeners to understand this. And we really appreciate what you're doing down in Illinois at your tertiary care center.
Thank you very much.
How long have you been working in this specific field, Dr. Asi?
My background, Ted, is neurology. So actually, I did a neurology residency. I was at Medical College of Wisconsin. And then I did actually neurocritical care at the Cleveland Clinic, where we took care of a lot of stroke patients and hemorrhagic stroke patients, believe it or not. And then I pursued a stroke fellowship as well. And that was the beginning of my career. So I took care of a lot of stroke patients, both bleeding and lack of blood flow strokes. And later on, I felt that with the advances of stroke treatment that happened in 2015, 2016, is that I needed to do more and, offer patients advanced therapy. So that's when I went to University of Iowa and pursued this endovascular neurosurgery fellowship. So I would say I've been taking care of stroke patients easily over the past 10 years.
Great.
More so offering these treatments of endovascular over the last 2 to 4 years.
Great. What is the biggest surprise you've had in this field in the last, I'd say, few months or years, and why?
There are two interesting things about this. Is number one, the technology is advancing. We're having more devices. We're able to open more blood vessels. And that's really good. The challenges we have sometimes, and some of the difficulties, are when some of our stroke patients unfortunately don't make it on time. They're too late for multiple reasons. And that's what happens, is that when it's too late and the brain tissue is already affected by the stroke, there's not much we can offer. And that's one of the major challenges we're having in the stroke field. As I said, that's why a lot of education has been happening, sponsored by the American Heart, by the National Institute of Health. And I would like to take the opportunity as well, Ted, to thank all the EMS, the first responders, because really they're the ones who get the patients to the emergency departments. And without them, we cannot do this, for sure.
That's a great point you make, Dr. Asi, because I think, correct me if I'm wrong, but the communication with our EMS workers and the emergency department is critical.
Oh, definitely. And as I said, they're doing the big part of the work by screening the patients, by doing we have scales that the EMS uses for identifying the severity of a stroke. So most of the time, in a lot of emergency departments, what happens is that the EMS notifies the ER that they're coming to that there's a stroke patient. This is the score, the pre-stroke assessment score. So the ER is ready. So we get the ball rolling even before the patient arrives to the ERs, that we have the room ready, the CT scanner know there's a stroke patient coming in. So we have everything lined up. Another interesting part too with the advances of technology is that right now, even the physicians, we get notified immediately when the patient's in the scanner, and we're able to look at the images before even the patient gets off the CT scanner. So if we need to activate our teams, it happens immediately.
That's great coordination of care.
It takes a lot of work, and it's not, it takes a village, really.
Right.
It starts with our EMS partners, the fire departments, the ER physicians, the radiology section in the hospital, the pharmacist that, mix the TPA, the radiology department, neurocritical care unit. So it takes a lot of work, a lot of people to ensure that we get the patient to the right place, the correct time. And the whole goal of doing this is preventing disability,
Right.
making sure patients go back to their normal lives. Even on the state level, a lot of rules and laws have been made to support, stroke patients, to support decisions that ensure equal care to all patients.
Great. Dr. Asi, how do you continue to learn and stay up to date in this field?
That's a challenge to all physicians, not really just physicians in my field, but I think what's important is to make sure you're up to date is going to national conferences, number one, attending webinars, making sure that there are weekly conferences in your department or biweekly to discuss cases with your colleagues. In our field of endovascular neurosurgery, there's also conferences that you could see live operations being broadcasted online, difficult cases, continuing to read, journal subscription. It takes a lot of work. And I still remember my chairman telling me, if you don't read medical literature at least 2 hours a day, then you're not up to date. And that could be challenging, really, Ted. I'm not sure. What's your thoughts about this?
Oh, yeah. I mean, I feel the same way. I think you have to try to read and stay up to date as best as possible. But like you said, 2 hours a day is very challenging.
I agree. I'm not sure I want to do that. But the issue is that, especially in the stroke world, since 2015, in the last 7 years, a lot of advances occurred. A lot of new devices came out that are FDA approved. So that could be challenging sometimes, and keeping up with the data, with all the trials. It takes time. It does, for sure.
Right. Dr. Asi, if you had to sum up the specialty for our listeners and just some takeaway points, what would you have to say?
So the specialty, endovascular neurosurgery, 30% of what we do is emergent, treating strokes, treating brain bleeds. And then we do also take care of aneurysms that are found incidentally, patients that need other cerebrovascular diseases to be treated. We take care of that as well. The most important message that I want to deliver, because of next month is the Stroke Awareness Month, and is never hesitate to reach out, to call 911 if you suspect someone in front of you is having a stroke. I think that's what I want to really emphasize, because if it's too late, patient doesn't show up on time, that results in disability and patients not able to go back to their normal life. And that's frustrating to the patient, frustrating to their families, frustrating to the medical personnel that cannot provide the help that they want to. So that's really the important message I want to deliver. And the other issue also is there's always people on call to take care of these stroke patients. So that's the most important message I want to deliver. I know that we spoke a lot about ischemic stroke during this podcast, the lack of blood flow stroke, but that's really what we mostly encounter in the community. The hemorrhagic stroke is as important, and sometimes they present with the same symptoms. We know it's hemorrhagic after the patient show up in the emergency department and we do a CT scan and see a brain bleed. So I may not want to go too much into that detail right now,
Sure.
Ed, for the hemorrhagic stroke, because I think the goal is to get the patient to the right place, and then we'll take it from there. And the stroke symptoms, most of the time, are the BFAST symptoms, which is the balance, the vision, the face weakness, the arm weakness, and the speech problems. And then if you can call 911, that's it. The only addition I would make for bleeding strokes is that patients will suffer from sometimes a massive headache, what we call a thunderclap headache. And if that happens, if someone suffers from the worst headache of their life, and that's associated with symptoms as well, even if it's not associated with symptoms, that could be a sign of an aneurysm that burst, an aneurysm that ruptured. So you also call 911. In simple words, that's what I want everyone to look out for. The symptoms, thunderclap headaches or the worst headache of someone's life, then you call 911.
Right, definitely. And remember, folks, when it comes to stroke, time equals brain, okay? Every minute, every second matters.
That is correct.
Well, thank you so much, Dr. Asi, for your time and being a guest on MD Roundtable. Really appreciate you spending the time here, okay?
No, thank you very much, Ted, for the opportunity. It was really a good experience for me trying to deliver this message out through your podcast. Thanks for all what you do.
You're welcome. Appreciate it. Folks, just a reminder, don't forget to leave a review of MD Roundtable podcast on Apple iTunes, and please don't forget to subscribe. Stay tuned for our next podcast coming to you shortly. Thanks again for joining me again today, and have a great day.